Hi, everyone. My name is Tommy. I will be presenting meningitis. I am a current pharmacy resident here at Loma Linda University Health. Um, yeah, so we'll go ahead and get started. So here are our learning objectives for the day. So this is going to include describing the pharmacokinetic and pharmacodynamic characteristics of medications used for meningitis, explain the pathophysiology and recognize the clinical presentation of bacterial meningitis, identify patient risk factors with common bacterial pathogens, and which organisms that need to be empirically covered in meningitis initially, and then implement a first-line patient-specific treatment plan for meningitis using the IDSA meningitis guidelines. So this is going to also include employing monitoring parameters necessary for both safety and efficacy while treating, and then implementing an appropriate patient-specific vaccination regimen to prevent meningitis in the first place. All right. So our overview for the day. So the meninges is what is covering our central nervous system. So this is a thin tissue that is surrounding the brain and spinal cord, as we can see here. Um, so in meningitis specifically, the meninges is becoming inflamed due to various reasons, which can include bacterial, viral, fungal, and we'll talk more about the differentiations of each one later on, but we'll take a great focus on bacterial meningitis. So once our meninges becomes inflamed, it looks vastly different. This is going to affect what can penetrate the CNS or not. And the reason why we care about this so much is that it is associated with high mortality rates if poorly diagnosed or undertreated. So again, our anatomy of our central nervous system includes the brain and then the spinal cord. And encapsulating all this again is the meninges. And why is that important? So our meninges is broken down into three different layers. So this includes the dura mater, the arachnoid matter, and the pia mater. And all of that is going to protect our precious cerebrospinal fluid and then the central nervous system under that. So more on this regarding the anatomy of it, and this is going to play a role in what we need to know about in order to treat it properly, is that the blood vessels are able to vascularize the CNS. And the blood-brain barrier regulates what can cross between the blood vessels and the CNS, as we can see here. Uh, So the pathophysiology behind this is going to include essentially bacteria crossing into the CNS, where the CNS should definitely be a sterile environment. You should never find naturally any bacteria behind there. So there are going to be different modalities in which the bacteria is able to cross into the central nervous system and pass that blood-brain barrier. So at first, our first thought is going to be bacteremia. So if we have high levels of bacteria within our bloodstream, then that can incite, lead to organisms passing the blood-brain barrier and then contaminating our central nervous system. Other thoughts are going to be bacterial colonization of our mucous membranes, especially our nasopharynx. Another one is going to be our oropharyngeal area, and then neurosurgical procedures. So this is in the case of like any procedures that might happen where there's like open brain or open head surgery, where this is going to provide an opportunity for organisms to directly bypass and enter the central nervous system. So that is high risk in terms of what can be a post-procedural complication. And then furthermore, if we have any head trauma, where that is going to be direct insertion of organisms from the outside into our sterile environment. So more on the pathophysiology behind this. So we have our pathogens that can enter our bloodstream, as we talked about previously. And the risk here is that they're going to enter our sterile environment. So once the bacteria are able to cross over and enter the sterile environment, the bacteria can then multiply. And these bacterial fragments will trigger the host's immune response, and this is going to end up leading and causing inflammation, as we saw in the initial images in the past few slides. And with inflammation, this is going to like essentially be a positive feedback loop where the pro-inflammatory state can further increase penetration into the CNS. So by increasing the penetration and these gap junctions are going to increase in size, more can enter the CNS, and whether that is going to be more bacteria, alternatively, that can also be more antibiotics that can pass through. So that is why it's important to have treatment that can penetrate the central nervous system. So while the blood-brain barrier has propensity to protect, it also acts as a great hurdle for us to provide treatment once the immune system or once the central nervous system is compromised, which we'll talk about more about later, and what antibiotics are able to cross into the central nervous system. So the epidemiology behind this and why it matters. So the community-acquired meningitis, so this is going to be regarding, in the last study was like in 2014, where in the United States, we had about 1 in every 100,000 patients who had cases of community-acquired meningitis. And we'll talk about the differences between community-acquired meningitis versus hospital-acquired later on. And then in 2014, in sub-Saharan Africa, so that there's 1,000 patients per every 100,000 patients who had community-acquired meningitis. So this is vastly higher, and sub-Saharan Africa specifically is one of those countries that is endemic and has a meningococcal epidemic going on, which is a risk factor that we'll talk about later too. So moving forward, hospital-acquired meningitis incidents may occur from anywhere from like less than 1% to up to 10% of patients having that invasive neurological procedures. And as we talked about previously, this can include different things, right? Craniotomy, ventricular catheters being placed, and then head trauma, such as a skull fracture, for example. So any of these instances are going to provide opportunities for our sterile environment to become contaminated with bacteria, and then essentially seed for growth. So more on the risk factors for meningitis. So meningitis has risk factors for those who are essentially on the both ends of the age spectrum. And this can include patients who are extremely young and then extremely old. And then even in our guidelines, we break it up into various age categories. So patients who are immune suppressed, these are going to include patients who have transplants, chemotherapy, and AIDS. So any of these patients are going to be more at risk for developing meningitis and having their CNS compromised. This also includes patients who are going to be in large groups of people, such as college campuses or even prisons. Furthermore, patients who travel to the endemic regions, as we kind of talked about previously, so this is going to include sub-Saharan Africa. And then another risk factor is going to be the presence of ventricular peritoneal shunts, where essentially some patients might have too much CSF fluid, and that can increase their intracranial pressure, where a specific shunt is placed. So this is called a VP shunt typically, and the VP shunt is going to help funnel some of that CSF fluid down into our peritoneum to help relieve that intracranial pressure. But anyway, this is essentially another opportunity for bacteria to seed and compromise our central nervous system, is what I'm trying to get across here. And then patients who have splenectomy, these are going to essentially also cause the patient to be immunocompromised as well. And then if they are under-vaccinated, then another risk in getting infected. All right, so the clinical presentation of meningitis is going to present different for every patient. However, there are some common symptoms that we try to keep in mind. So this is going to include headaches, where the patient might describe it as like the worst headache that they've ever gotten. If they are febrile, and then have nuchal rigidity. So nuchal rigidity is going to be essentially a stiff neck where they have difficulty moving it. And then altered mental status, where this is typically described as ANO times 1, 2, 3, and 4. And all of these are going to essentially, or ANO stands for alert and oriented. So that is going to be the provider assessing the patient's mental status, where they'll ask various questions to the patient and see how they respond. additional information that can help the providers when the family members are able to describe to us where the patient is at a baseline, so we know if it has vastly changed or not. So of these top four, these are what are going to be in most meningitis cases. Additionally, the patient might also present with nausea and vomiting or photophobia, so they might be afraid and shun away from bright lights. All right. And then in meningitis, some other big signs that we are looking for are going to be the Kernig sign. So this is going to be essentially the inability to straighten the leg when the hip is flexed at a 90-degree. So the patient is unable to do so. And then the other sign is going to be the Brudzinski sign. So when the neck is flexed, as we can see here, then the knees will flex too, or want to at least flex too. And then both of these are going to be part of like the physical examination that the provider does upon seeing the patient. However, both of these are not guaranteed to be, like if a patient is positive for the Kernig sign, does not automatically rule in meningitis. It becomes like a big thought that the team has to consider. However, it will not be like 100% guaranteed that the patient has meningitis. So they do still have to further test, but this will be a good sign for the team to like base it off of. And then as we talked about earlier, there are two different types of meningitis. So we have our community-acquired meningitis, and then later on we'll talk about hospital-acquired. So for community-acquired meningitis, our guidelines, the IDSA guidelines, breaks it down into 4 different age groups. As we mentioned here, we have age groups of patients less than 1 month years old, and then patients anywhere from 1 to 23 months old. So both of these are not going to be included in this lecture, and we are only going to essentially focus on the adult side of things. And you can hear more about it later in your pediatrics lecture. So the 2 groups we'll be focusing on are the 2 to 50 years old and then above 50-year-olds. So specifically with our 2 to 50 years old patients, there are going to be specific pathogens that we need to keep in mind in order to empirically treat at the start. So this is going to include Streptococcus pneumoniae and then Neisseria meningitis. So of note, Streptococcus pneumoniae is going to be the most common cause of community-acquired meningitis. So these organisms need to always be treated empirically, and then we'll talk about further de-escalating and narrowing our therapy as we gain more and more information. And then patients who are above 50 years old, these still include common pathogens as we saw in the previous group. However, there are a few other organisms that we need to cover for. So then this opens up the opportunity for Listeria monocytogenes, where this is going to be a common organism that affects essentially the age spectrum. So those who are really old, as we can see here, this is the greatest age group that we have for meningitis, as well as the lowest age group of less than 1 month of note, although we are not specifically talking about less than 1 month patient. In addition to that, we also need to cover for gram-negative rods, or commonly referred to as GNRs, throughout this talk, or E. coli and Klebsiella. So all these organisms need to be empirically covered for at the start of our meningitis treatment. So how do we determine if a patient has meningitis or not, right? So we talked about those various symptoms and the Kernig sign and Brudzinski sign earlier. However, those are going to help us lead to having the suspicion, but we need to confirm whether or not the patient has meningitis or not. And in order to do so, we are going to have to do a couple different things first. So before we administer any antibiotics, what needs to be done is to get blood cultures. And the reason why we need to get blood cultures before administration of antibiotics is to prevent the antibiotics from like killing off any bacteria. Although it might not happen that fast, this is the way for us to guarantee what was the patient like before anything was done. In addition to this, imaging can be done, but not always. So this is a plus or minus thing. And then we need to do a lumbar puncture, or the team does. So a lumbar puncture is going to be where the patient essentially bends over in their bed, and a needle is going to be inserted. So this is going to be inserted into the central nervous system. And specifically what they're doing here is that they're drawing out cerebrospinal fluid or CSF fluid. And with this fluid, a couple things are being considered. So as soon as they enter it, they're going to measure the opening pressure that is released upon penetration of the central nervous system and penetrating the meninges. So that opening pressure is noted. And then once we have that CSF fluid, we're going to use this for various things. So we're going to analyze it and see the breakdown of all the components within it. And that's going to help us determine what is the etiology of our meningitis. And then it's also going to be gram stained to see whether it's gram positive or gram negative and give us an idea what needs to be treated. And then culture to see what specific organism is isolated and needs to be definitively treated at that point later on. However, just to give a general timeline, analysis is what is going to come back first. Gram stains are typically fast as well within the same day. However, a culture is going to be what is slower in the process of things, where this might take 2 to 3 days before it is finalized and we have susceptibilities of what to treat. So more on that imaging as we mentioned previously. So the imaging was plus or minus, but if they were to proceed with it, a cardiothoracic or CT scan of the head is used. And this is considered when patients are immunocompromised or they have a history of CNS diseases in the past. And this can include anywhere from like a mass lesion noted, strokes, or a focal infection. Papilledema is also one of those risk factors that will encourage us to get a CT scan of the head. Any new onset seizures within the past week are also important. And then any abnormal level of consciousness. So if they are altered or have difficulty maintaining consciousness. And then focal neurological deficits as well. So any of these are going to incite the team to get a CT scan of the head. As we mentioned earlier, one of the things that the team is going to do is obtain a lumbar puncture and obtain that CSF fluid. And in order for us to analyze it, and while analyzing it, that is going to help us determine the etiology of the meningitis, whether it's bacterial or viral, is what we're going to be focusing here on. However, some of the other things that a CSF analysis can help rule in and out are going to be like idiopathic causes, or even fungal cases, or even tuberculosis. So when we are entering the CSF, our CNS, then our normal pressure, opening pressure is going to be anywhere from 50 to 200. However, it is going to be elevated in cases where there is a bacterial etiology. In terms of viral, it can be anywhere from normal to elevated. And then the next thing that we're looking for in the analysis is going to be the appearance of the fluid. So if it's clear, that can either be normal or viral. So that does help us in a way where it rules out the bacterial idea, because if it was bacterial, then it's going to be turbid and cloudy in appearance. And then for our white blood cells, this is typically very low, less than 5. However, in bacterial cases, this is going to be elevated, as well as viral cases. And then our glucose is, this is going to be the CSF glucose. So CSF glucose is going to be 50 to 80, and this is going to be lower in cases of bacteria and within normal for viral cases. And then the next thing we need to consider is the comparison of the CSF glucose to our serum glucose. And then this is going to help us create a ratio for our patients. So our normal ratio for a patient is going to be 0.6. However, the way we calculate this is going to be comparing it to our normal blood sugar level. So for example, if my blood sugar is 200 and my CSF glucose was 80, so then you'll do 80 divided by 200, comes out to be about 0.4. And that is how you calculate this ratio specifically. And based on that ratio, that will help us determine whether it's viral or bacteria as well. And then moving forward, our proteins are going to be 15 to 40. And then it's going to be elevated in the bacterial cases, and then whether it's going to be normal to elevated in the viral cases. And then one of the big things that help us determine within our CSF analysis are going to be what cell is predominantly found. So lymphocytes are what are normally found. However, in bacterial cases, a big telltale sign are going to be the presence of neutrophils, whereas in virus, those are going to be lymphocytes as well. And then if we were to gram stain a completely sterile CSF fluid, that is going to come out negative, where you shouldn't be able to gram stain out any organism. However, that is going to be the same case if it is viral. A gram stain will not determine or detect anything. However, if it is bacterial, you are going to either see gram positive or gram negative organisms. So you will find something there. And then of note, our CSF lactate greater than 4.2 millimoles per liter is also going to indicate that it is likely a bacterial etiology. Okay, so we talked about the organisms earlier and we talked about determining what is the etiology of it. So we're going to take a focus on the treatment of community-acquired meningitis now. So this is per the IDSA guidelines, last updated in 2004. So we talked about these two organisms in the age group of 2 to 50 earlier. So highlighted are going to be what organism it is and what part of the empiric treatment is going to be treating that organism specifically. So for Streptococcus pneumoniae, in this case, both vancomycin is covering it as well as third-gen cephalosporin. And now we are treating it with two different agents, but the reason why we include vancomycin in this regimen and empirically is that in the off chance that the Streptococcus pneumoniae is resistant to one of the third-gen cephalosporins, whether it's ceftriaxone or cefotaxime, then it is being treated anyway. And that is important, right? Because again, meningitis is going to have a high mortality risk. So we do want to definitely be treating it. However, there is some debate whether the vancomycin is truly necessary or not, but this is what is remaining in the IDSA guidelines and what is commonly done. So both agents will still be used empirically. And then, however, it is important to note that the vancomycin here is used with intention, as previously mentioned, and not to intend to treat methicillin-resistant Staphylococcus aureus, or MRSA. That is not the intention of the vancomycin here. And then moving forward, we have Neisseria meningitis, where this is specifically being treated by that third-gen cephalosporin, as we list here, whether it's ceftriaxone or cefotaxime. Okay, and then in our next age group, above 50 years old, we still use the same two agents as previously mentioned. However, we add on one more. So we add on ampicillin. So the ampicillin is directly treating the Listeria monocytogenes. And then our gram-negative rods are being covered by the third-gen cephalosporin. So both the E. coli and Klebsiella are being treated by these agents below. And then if we are concerned about hospital-acquired meningitis, then some of the other patient groups or risk factors that we're thinking of are going to be whether the patient has head trauma, their status post-neurosurgery, or they have a CSF shunt in place. So as we talked about earlier, that ventriculoperitoneal shunt. So we'll start off here. So whether it's head trauma or post-neurosurgery, those are going to make us think about specific organisms. So this includes Staphylococcus aureus in this case now. And then coagulase negative Staphylococcus, or commonly abbreviated as CONS. This can include organisms such as Staphylococcus epidermidis or Staphylococcus lipdonensis. And then we are still concerned about gram-negative rods. However, now we are also concerned about Pseudomonas and having Pseudomonal coverage. So in this case, our vancomycin is going to be covering both the Staphylococcus aureus as well as the coag-negative Staphylococcus. And then our empiric treatment is also going to consist of ceftazidime, cefepime, or meropenem, all of which are covering Pseudomonas empirically as well. So we have that covered, as well as all the other gram-negative rods. And then our empiric regimen stays the same, even when there is a CSF shunt in place. However, where it slightly changes is that the common pathogens that are being covered in CSF shunt patients are going to include Propionibacterium acnes, or also known as Cutibacterium now. However, vancomycin is going to cover that anyway. So no changes to the overall empiric treatment for any of these three groups. And then of note, when we're thinking about like post-surgery, post-neurosurgery, the time period for that when we're thinking about hospital-associated meningitis is going to be 7 days. So let's say it's a month later after my neurosurgery, then you wouldn't be too concerned about the patient having hospital-associated meningitis. If they were to present with suspicion for meningitis, then we'll most likely suspect community-acquired meningitis. Okay. And then for our empiric therapy, this is going to be our various medications and dosing regimens for at least the very common ones that you will see. So we'll start off with like a big one. So ceftriaxone is commonly used. So this is going to be 2 grams IV every 12 hours. And this is distinct from what we normally see in a lot of other scenarios where it's almost always seen as every 24 hours. So when you see it in as Q12, then it's likely for meningitis, sometimes also endocarditis. But otherwise, you're usually going to see every 24 hours in most other indications. And then some other big ones to note for dosing for you to know is going to be cefotaxime, which is dosed at 2 grams IV every 6 hours. Ceftazidime, 2 grams every 8 hours. Ampicillin is dosed pretty frequently at 2 grams every 4 hours. And then cefepime is 2 grams every 8 hours. Meropenem, 2 grams every 8 hours, and then vancomycin. We won't talk about like how to dose it specifically, but we do at least dose to specific goals in mind. Now, whether your institution uses a trough goal of 15 to 20, alternatively, some other institutions do dose based off of AUC, where it's specifically 400 to 600. Okay. So for our definitive therapy, this is going to be what is used for us to narrow our therapy once our CSF cultures have finalized. And this is really going to help us tailor the therapy to this specific patient, where our empiric regimen can range from either 2 to 3 different antibiotics. And our definitive therapy is going to be either 1, sometimes 2 agents. So it really helps tailor the therapy and what the patient is going to finish their treatment on. So our CSF culture finalizes, and that is going to report to us what specific organism grew. And 2, with that specific organism, it's going to list out the susceptibilities. And the susceptibilities are going to list the MIC, or mean inhibitory concentration. And these MICs are going to be what is the smallest antibiotic concentration needed to prevent bacterial growth, or this specific bacteria from growing. And with all these MICs, it's going to list out for various antibiotics. And with each MIC, it's going to correlate it to say whether it is susceptible to this antibiotic, or if it's intermediate or even resistant. And some key terms here are going to be whether it's pan-sensitive or pan-resistant. So if it's pan-sensitive to antibiotics, then essentially what you can imagine is that all the antibiotics listed are going to say susceptible. Well, now whether it says pan-resistant, you can imagine that all those antibiotics listed are going to say resistant. Okay. So for our specific organisms that grow, it's going to list out MICs. So penicillin MIC of less than 0.1, that's going to help us know that we can confidently treat with either penicillin G or ampicillin. And I'll take a focus on specific antibiotics throughout these lists and highlight specific tidbits that I want you to know for each one. So specifically for ampicillin, this is going to definitely need to be renally adjusted. And then we also have some alternative therapies. So alternative therapies for this can also include third-gen cephalosporin. So as we talked about previously, that's going to be our ceftriaxone or cefotaxime. And those are our IV options, right? We do not consider any oral options. So something like cefdinir does not work here. With ceftriaxone, some big things to highlight there are going to be that it does not require renal adjustments. So we'll talk about, we already talked about dosing previously. And then next up in our next MIC grouping, so 0.1 to 1, this is still going to include treatment with third-gen cephalosporins. And alternatives to that are going to be cefepime and meropenem. And the reason why these are going to be alternatives are that these are adding on unnecessary coverage. And what both these are covering unnecessarily are, for cefepime, is going to be Pseudomonas, whereas meropenem, it also unnecessarily covers Pseudomonas as well as anaerobes. However, that's why these are considered as alternatives. Some more specific things to know about each agent is that with cefepime, high uses can cause neurotoxicity, so that is a concern. And then in meropenem's case, usage may lower the seizure threshold, so it might not be as ideal in a patient who has seizure history. And then in the next up group, where we have patients with greater than 2 MICs, this is going to include a standard therapy of vancomycin plus either ceftriaxone or cefotaxime. An alternative to that we can consider is fluoroquinolones. And some big things to think about for fluoroquinolones are the adverse effects that are associated with them. And this can range from tendon rupture to hallucinations, increased risk of coronary artery disease, as well as So specifically for cefotaxime or ceftriaxone, if the MIC is greater than 1, then you are going to want to add in vancomycin as well, in addition to that third-gen cephalosporin. And alternatively, fluoroquinolones can be used too. And then you can go through the Bacterial Meningitis breakpoints, but most of these are still using similar agents that we talked about previously. So the same principles still apply here. And then we'll fast forward down to Listeria monocytogenes. So our agents of choice are going to be either ampicillin or penicillin G. And then another consideration here is going to be Bactrim, Septra, or trimethoprim sulfamethoxazole, however you want to call it. And some big points to highlight with this specific drug usage is going to be that Bactrim is associated and can cause hyperkalemia. So in patients with already high potassium levels, or that can also be a point of monitoring if we are starting someone on Bactrim. And then of note, since we are starting a Bactrim, it is important for us to evaluate if the patient has any allergies, because most patients, or some patients might report that they have sulfa allergies. So that is something important to know and think about when initiating any agent, but specifically this one too. And then next up, we have Streptococcus agalactiae. So this is mainly an organism that is considered in one of the other age groups that we didn't talk about too much today. So I'll skip over this one. And then our gram-negative rod. So it's primarily E. coli and other Enterobacteriaceae. So here we can still consider third-gen cephalosporins as our main standard therapy. And we have some other options as well for alternatives. Now, if a patient reports that they have a cephalosporin allergy and they had an anaphylactic reaction to ceftriaxone, then a common agent that we use in patients who have allergies is going to be aztreonam, where it has excellent gram-negative coverage, and that's really where you'll see it the most used. and then some of the other agents that we previously talked about too. Okay, so wrapping up the list, we have Pseudomonas. So some of our other agents are going to be, so as we talked about previously, cefepime, but another one to consider that is a third-gen cephalosporin is going to be ceftazidime. So the only third-gen cephalosporin that does cover Pseudomonas as well. And then we'll fast forward down the list, but still definitely look throughout these other ones. But of note, down here now, one of the other agents that we are using is going to be linezolid in the case where there is Staphylococcus aureus that is methicillin resistant, and for some reason we cannot use vancomycin. Whether they have like a vancomycin reaction syndrome where we might not want to use vancomycin, then we can consider linezolid as well. But with linezolid usage, there are going to be big things to look out for. So linezolid should not be initiated in patients who are on serotonin reuptake inhibitors, so SSRIs, SNRIs. This is going to be cases where we do not use linezolid as that's a big drug-to-drug interaction. Other adverse effects to look out for are going to be things such as bone marrow suppression, where that is going to be monitored through complete blood counts or CBCs, where that is us mainly looking at the red blood cells, white blood cells, and platelets, where if the patient has bone marrow suppression due to linezolid, then you might see a decrease in all three of those. So you'll see a decrease in red blood cells, white blood cells, and platelets. So that is going to be an important monitoring parameter for linezolid. And then down here, if we are treating enterococcus, and then some things to be mindful of. So if it is ampicillin susceptible, we can use ampicillin, and some may add in gentamicin as well. And gentamicin is really added in here for synergy. So later we'll talk about how gentamicin does have poor CSF penetration regardless of inflammation is present or not. But it is used for synergy reasons. So even though small amounts pass into the blood-brain barrier, that small amount is going to help synergistically work with beta-lactam, where the beta-lactam will help inhibit the cell wall synthesis, and then the aminoglycoside, in this case gentamicin, is going to be able to enter the bacterial cell and then inhibit protein synthesis there. And overall, our summative effect of all this is that it's going to help increase the bactericidal effects of clearing the CSF of our bacteria. So the faster we proceed and really clear the CSF is how we're going to treat meningitis the best here. Some adverse effects to be mindful of when using gentamicin is going to be looking out for ototoxicity and nephrotoxicity, where this is going to require therapeutic drug monitoring, where we are going to be specifically looking at the troughs of gentamicin to look for toxicity. Okay. And then next up, we have our adjunctive therapies. So one of the big adjunctive therapies used in meningitis is going to be dexamethasone, so steroids. And this is specifically given in a dose of 15 mg per kilogram, whether that is oral or intravenously, most likely intravenously, every 6 hours for the next 2 to 4 days. However, the timing of this is very important, where it needs to be started prior to or at the same time of first administration of antibiotics. So if a patient has already been on antibiotics for 1 day, and then now the team wants to start dexamethasone the next day, then it should not be used where there is no benefit seen. However, the greatest benefit that we see is when it is used prior, so roughly like 20 minutes prior, or at the same time as administration of antibiotics. So those are going to be very important for you to know. And really why we use dexamethasone in this case is that it's going to help decrease the inflammatory response, leading to reduction in both morbidity and mortality. And overall, this decreases the sequelae or all the complications that can ensue from meningitis. And that can include cerebral edema, elevated intracranial pressure, or commonly referred to as ICP, or altered cerebral blood flow. And the indication for this is going to be bacterial meningitis caused by Streptococcus pneumoniae. And one of the big things is going to be that you might be thinking of is how do you know it's caused by Streptococcus pneumoniae, right? Because this is going to be something that is isolated later on. But at least in our empiric regimens for both the age groups that we're looking at, so whether it's 2 to 50 or over 50 years old, both those age groups have Streptococcus pneumoniae listed as an organism that we should be empirically treating for already. So if it's in either of those age groups, then you should, then it is indicated that dexamethasone can be added on to the start of therapy. And then since the CSF culture will not result for about 2 days, then it's fine to start on dexamethasone. And then overall, if our cultures come back before like the duration of dexamethasone is up, so it was anywhere from 2 to 4 days, right? So if the cultures result as not Streptococcus pneumoniae, then you can go ahead and discontinue the dexamethasone before those 4 days are up. And then our duration of therapy. So this is going to depend on what organism is cultured out from our CSF. So if it's Neisseria and Haemophilus influenzae, then both these agents are going to require 7 days of appropriate antibiotics. So from the start of empiric regimen all the way till after we have defined therapy and a few days extra from that. If it's Streptococcus pneumoniae, then this is going to be anywhere from 10 to 14 days. And then if it's Streptococcus agalactiae, so group B strep, this is going to be 14 to 21 days. And then our gram-negative rods, whether that's E. coli, Klebsiella, Pseudomonas, this is going to be 21 days of therapy. And then Listeria needs at the very least 21 days, but any more than that is up to debate. And how the patient clinically presents. So the next up is we're looking at antimicrobial CSF penetration, and the penetration of antibiotics past the blood-brain barrier is going to really depend on whether or not there is inflammation. So we'll categorize into three different groups, whether it's good, it's fair, or it's poor. So if it's good, that is going to be that the antibiotics can cross regardless of inflammation being present or not. And this is going to include sulfamethoxazole and trimethoprim, fluoroquinolones, linezolid, metronidazole, acyclovir, and rifampin. Now, the next group we'll think about is if it's fair. So it's therapeutic and can cross under the caveat that there is inflammation present. So that includes vancomycin, most IV beta-lactams. So this includes penicillins and cephalosporins such as ceftriaxone, cefazolin. And then carbapenems, macrolides, aztreonam, tetracycline, and daptomycin. And then in our poor category, so this is going to be non-therapeutic regardless of the presence of inflammation. This is going to be aminoglycosides, oral beta-lactams, and then select IV beta-lactams. So this can include Zosyn or piperacillin and tazobactam combination, and then clindamycin as well. So overall, for our patients that we're treating for meningitis, we are going to have various monitoring parameters. So what we're looking for is that there is improvement in symptoms. So mental status should gradually improve, headaches should dissipate, the photophobia should go away, and the fever should go away as well. For an efficacy standpoint, we are also primarily looking at the serum white blood cell count. And of note, it says serum. So that is going to be vastly different from monitoring our CSF white blood cells, because a repeat lumbar puncture is not routinely done while on antimicrobial therapy. However, it is sometimes done in the case that we have started antibiotics and there is no clinical response after 48 hours. And then at that point, the team may consider a repeat and then further analysis then. Okay. And then for our prevention standpoint and preventing all this from happening, we are considering various organisms, and some of these do have vaccinations available. So for Streptococcus pneumoniae specifically, please refer to Dr. S. lecture. We'll mainly be focusing on the vaccinations possible for Neisseria meningitis. And then Haemophilus influenza does have a vaccination, but that is done during your pediatric years and will not be covered in this lecture. So for our meningococcal vaccine, this is specifically protecting us against Neisseria. And there are two different sets of vaccines available. So that is going to be one that covers serogroups A, C, W, and Y. And the brands for that are going to be Menactra, Menvia, and Menquadfi. For the other vaccination available, that is specifically going to cover serogroup B. So that is going to be Bexsero and Trumenba. And then both immunization series will be typically completed by age 16. However, there are specific situations where you may consider providing another dose of this quadvalent meningococcal vaccine. So this is going to be in scenarios where there is anatomical or functional asthenia. So, or that also includes patients who have sickle cell disease. So overall, if they either have their spleen removed or they have sickle cell disease, and then, or they have an HIV infection, in either case, you can consider providing 2 doses of this quadvalent vaccination given 8 weeks apart. And then you can consider revaccinating every 5 years if the patient still has risk. So if either risk still is applicable, then you can revaccinate them 5 years later. And then for patients traveling to countries with epidemic meningococcal disease, so as you mentioned earlier on in the lecture, this is going to include countries such as sub-Saharan Africa. And this may apply to patients who, well, one, they might just travel a lot. And then 2, patients who are enlisted in the military and have to travel to these countries. Alternatively, if the patient works in a lab and specifically deals with Neisseria, then either of which you can consider 1 dose of this quadvalent vaccination and then again revaccinate in 5 years if the risk still remains. And then for patients who are first-year college students living in residential housing, so on-campus housing with numerous other students, then in this case you can consider 1 dose of the quadrivalent vaccination. Now, if the patient is a college student and is in first year, however, they live at home, then this recommendation does not apply, like if they live at home with their parents. And then other situations where meningococcal B specifically serogroup is going to be, again, if they have anatomic or functional asthenia or sickle cell disease or works in a lab with Neisseria, then you can consider 1 dose of meningococcal B specifically after their primary series. And then you can revaccinate every 2 to 3 years if the patient is still at risk. These are my references. And if you have any questions, feel free to reach out. My email is listed at tommythai@llu.edu. Thank you and have a good day. Bye.